I'll be talking about management of suprachoroidal hemorrhage. It is collection of blood in the suprachoroidal space due to rupture of posterior ciliary arteries. It can practically happen after any ocular surgery, but it's most commonly reported after glaucoma surgery, and the incidence rate ranges from about 0.7 to 2% in different reports. It occurs due to high preoperative IOP, which drops suddenly, and is a potentially vision-threatening complication. Major systemic risk factors include use of anticoagulation, advanced stage, atherosclerosis, ischemic heart diseases, respiratory diseases, etc. Major ocular risk factors include history of glaucoma, aphakia, pseudoexfoliation, presence of a choroidal hemangioma, previous ocular trauma or ocular surgery, use of mitomycin C during trabeculectomy. Intraoperative risk factor, most important, is prolonged or complicated eye surgery, especially complicated by vitreous loss. And postoperative risk factors include hypotony and Valsalva maneuvers. In order to prevent it, preoperatively, we have to lower the IOP, manage hypertension, and stop any anticoagulants or antiplatelets. During the surgery, again, we have to manage the patient's systemic parameters. In the post-operative period, it is essential to avoid all forms of trauma and avoid hypotony. In extreme cases, high-risk cases, you can also avoid analgesics with anticoagulant activities such as ibuprofen and diclofenac. Intraoperatively, when it happens, there are certain signs which can help you in identifying it, which include increased IOP, sudden shallowing of anterior chamber, change in the red reflex, and vitreous prolapse. So if it is suspected of happening intraoperatively, you have to promptly close the surgical wound site. You might have to cut the tissue, compromise iris and the vitreous tissue so as to achieve prompt closure. In very rare situations, if you cannot reposit any tissue, you can try and drain suprachoroidal hemorrhage then and there, then reposit the tissue and suture it, but it should generally be avoided, and suprachoroidal management should be left for a later date. When detected in post-operative period, patients present with intense pain, decreased vision, nausea, vomiting, and headache. Slit lamp examination will reveal a shallow AC. There might even be vitreous prolapse. Indirect ophthalmoscopic examination will reveal loss of red reflex with choroidal mounts. So ultrasonography plays a very, very important role in diagnosing as well as follow-up of these patients. You see these dome-shaped detachments with spikes in the suprachoroidal space. If there is high internal reflectivity in the suprachoroidal space, it is suggestive of clotted blood, which will be difficult to remove. If there is low internal reflectivity in the suprachoroidal space, it is suggestive of lysed blood, which will be relatively easier to remove. On follow-up, we have to assess the state of liquefaction and the height of CD. If the height is reducing and the liquefaction is increasing, you can probably simply observe such patients. But if the height is increasing, or if there is appositional choroidal detachment, aka kissing choroidals, then you have to surgically drain it. Of course, IOP and inflammation has to be managed medically. It is generally said that it takes about 7 to 14 days for the clots that have formed in the suprachoroidal space to lyse completely, and this is when you should ideally plan for a surgical intervention so as to achieve maximal drainage. But there are certain indications where you have to intervene early, which include a coexisting RRD, central retinal apposition, because it increases the risk of retinoretinal adhesions if it persists for more than 3 days, high intraocular pressure, and deteriorating vision. So there are basically two surgical approaches to manage it. One is a sclerotomy, and this is a video courtesy of Dr. Rohan Chawla. This was a patient who was referred to us after a phaco surgery. He had developed a positional suprachoroidal hemorrhage. We have secured an AC maintainer to achieve positive pressure during the intervention and done a localized peritomy inferotemporally. In this particular case, we have made a large sclerotomy, about 4 mm in size. And as soon as you enter in the suprachoroidal space, you can see a little bit of fluid starts egressing out of the sclerotomy, which is an indicator that, yes, this is the end point of the sclerotomy. Then by using a cotton tip applicator, you can apply pressure over the globe, and the blood comes out very easily when you're using a large sclerotomy like this. In this particular case, we did an indirect ophthalmoscopic examination at the end of procedure and saw that there was a large nasal tear. So we did a combined VR surgery, and the patient's vision was 5/60 after about 3 months. This is another surgical video, and nowadays we would generally recommend making a smaller sclerotomy. This is a 2 mm sclerotomy made about 8 mm behind the limbus. Of course, with smaller sclerotomies, you might have to do a little more manipulation. You might have to use additional instruments so as to keep the lips of the sclerotomies apart. The drainage might be slow, but usually sufficient drainage can be achieved by such small sclerotomies also. A modified technique that has come up recently is using a trocar cannula system inserted acutely into the suprachoroidal space. So here's a surgical video of the same. In this particular case, there was suprachoroidal hemorrhage post-trabeculectomy. Again, we have secured an AC maintainer to achieve positive pressure. A 23 gauge non-wall trocar cannula is being inserted into the suprachoroidal space, and you can see as soon as we took out the trocar, the blood starts egressing out through the cannula. You might have to do a little bit of manipulation that helps in removal of more blood, because sometimes, because the lumen of the cannula is small, the even very small clots might occlude it. And you can see how well the glow has improved from what it was to begin with. These are the pictures of the same patient. So drainage can actually be done anywhere between 4 mm to 12 mm. That is the usual extent of suprachoroidal hemorrhage. We would usually now recommend draining somewhere around 8 mm. This is where the height of the choroidal detachment is maximum. So any iatrogenic damage to choroidal tissue or retinal tissue would be minimum. But yes, there are certain authorities which recommended draining at about 4 mm behind the limbus. If you have clots in the suprachoroidal space, then you are not left with any other option other than doing a sclerotomy. In this particular case, again, there was a positional suprachoroidal hemorrhage, but the blood was clotted. We made a small sclerotomy in the inferotemporal quadrant, and then by applying pressure over the globe, these clots were expressed out. Of course, you cannot remove all of the blood in such cases. The purpose is to remove blood which actually takes care of the oppositional status of the choroidal detachment. A lot of blood and clots might even be left at the end of the procedure. So suprachoroidal hemorrhage tends to have very, very poor outcomes, especially in the presence of a coexisting retinal detachment and a 360-degree suprachoroidal hemorrhage, where less than 10% patients actually achieve visual acuity greater than 20/200. To summarize, prevention is to be done by optimizing all parameters, both intraoperatively, postoperatively. Immediate wound closure is to be done in intraoperative suprachoroidal hemorrhage. Follow-up of the patients is done with serial ultrasonography to monitor liquefaction and height of CD. Ideal time of surgery, if you can wait for it, is about 7 to 14 days. Early drainage is warranted in certain conditions, which we have already discussed. And external drainage with trocar cannula system is a safe and easy method if the blood is sufficiently lysed. I would like to acknowledge all my seniors. These are not my ideas. These are my seniors' ideas, just my presentation. Thank you.
Thank you, Dr. Saurabh Verma.